CataractCoach.com, resident chop, a really excellent horizontal chop technique. It's case 250, and wow, I'm really proud of this young doctor. Let's watch the case here. We're going to show you the case unedited, and it's going to be pretty quick, only about 8 minutes here. So starting off with the paracentesis, that's being made. They're fixating that with a cotton swab in the other hand. And this technique I liked because it was just a really clean horizontal chop. Now, draping here is good. Lashes out of the way. There's some trypan blue dye. Patient's having a harder time maintaining fixation, and the eye is not quite in primary. I think that'll improve once the sedation kicks in a little bit, and perhaps when the intracameral anesthetic goes in. So there was the trypan blue dye. Let's see what's next. Now comes probably the anesthetic solution. Typically in our clinic, we're using 1% lidocaine, which is we start off with 2% preservative-free lidocaine and cut it 50-50 with BSS. And then now time for the viscoelastic. Let's take a look. A little bit squared outside the eye. I like that technique. Coming across here, and then there's a nice fluid wave going across. Good pressure, not too overfilled. And then now let's see the main incision. Yeah, checking the pressure. Firm but not overly firm, okay. And let's see the main incision. Remember, your incision plus your rexus, that's your signature. Everyone's going to see this even years later. You got to make sure that incision is pretty, of course, functional as well. So fixating the eye here with some forceps, starting a little groove there. Okay, I like that. You obviously nick the limbal vessels. And then tunnel length is pretty good. Slight change in angle and entering. Very nice incision. Incision there is very nice. That's going to seal up beautifully and be absolutely watertight. Now let's see the rexus. Okay, starting off with a cystotome. So cystotome rexus starting off, cutting across here, and then flipping up that capsule edge. Flip it over. Good, and now let's probably switch to forceps. All righty. We need, you're tending to squirt the cornea a little bit here. Here come the forceps. And now let's see that rexus going. Very nicely done. Good pivoting in the incision. Very nice pivot. Very good, very good. Keeping that rexus nicely centered. It looks like a good size. Probably going to be about a 5, maybe 5.25 millimeter rexus. We'll find out at the end of the case once the IOL's in. And now finishing that rexus. That is really clean. That's beautiful. So for case 250, wow, already fantastic. I'm very much impressed. Notice how the eye is now finally back in primary. Patient's probably sedation kicked in. Maybe the anesthetic, intracameral anesthetic helped. Here's some hydrodissection, tapping the nucleus, getting another fluid wave, tapping it. Let's see, does it spin? If it does not spin, you will not win. Now you can also see the incision outline. Nice stromal length there. And I like the nicking of the limbal vessels. That looks fantastic. Now let's see the phaco chop technique. It's going to be a horizontal chop. And what I liked here especially was placement of the instruments. The phaco probe is going to go not in the center of the nucleus, but sub-incisional. Watch. All right, clean up some of the anterior cortical material if you desire. And now look, it's going to go sub-incisional before, underneath that light reflex, the Purkinje image. Pre-placement of the chopper, now buzzing in, together and apart. Look at that. Beautiful chop. And the same thing here, rotating 9 degrees, pre-placement of the chopper, now buzz into the probe and chop in that window of time, that 1 second, beautifully done. Look how every chop just worked. Now the first quarter can come out, emulsifying that at the iris plane. Fantastic. That's really a great job. And then now I'd get at the second quarter and then chop the remaining half. Yeah, look at that. So very nicely done. Okay, another sub-chop, maybe creating a little smaller fragment. Get these 2 little fragments out then, and you'll be left with the 1 remaining heminucleus. So very, very nicely done. Eye staying in primary, good ability to float in the incision, nice maneuvering inside the eye, both hands being used. Let's see, buzz in with the phaco probe, bring it up, chopper goes around the equator, and another clean chop. So wow, just like that. This video is shown in real time. And again, this is a resident who's done about 250 cases. So certainly, if you're a physician in practice and you've already been doing 1,000 cataracts or more, you can achieve this, I promise. You just got to put in the work to learn it. And don't worry, at Cataract Coach, we'll help you. Last piece is coming up. I like the chopper in the safe position. And even this ball tip chopper, not my favorite, but hey, obviously it works. You saw the technique. And now switching over to the cortex removal. Rest of the case is going to be pretty routine. But I want to say that this is a very nicely done case. So what do we learn here for the chop? First, 100% of chops worked. There was no missed chop. I liked that the chop was pre-placed around the lens equator. I liked that the phaco tip was embedded in the sub-incisional space, just inside that sub-incisional rhexis, not in the center of the nucleus and not distal to the center of the nucleus. So therefore, the first chop that happened was quite successful, and it was able to split the nucleus entirely into two halves. That first chop, the chop was literally propagated to the entire diameter of the nucleus, so you got two halves. Then it was rotated, and now the other heminucleus was sub-chopped into quarters. Rest of the case just followed pretty easily. So this is something that you can certainly do, and you can learn this technique. And again, if you have a young resident surgeon who's achieving this during training, you can do the same, I promise. So you're cleaning up with the undersurface of the anterior capsular rim. That's with very low vacuum power. I would use the same vacuum settings, but just control the amount of vacuum with your foot pedal. Looks very clean. Here comes our viscoelastic, probably a cohesive agent. There it is, filling up the bag. And let's see the lens going in. And here you go. Looks like a single piece acrylic lens. Going to deliver that inside of the capsular bag. There it goes, nice and easy. And I like to see this last step so we can tell what's the size of the capsulorhexis. So let's see, get that Sinskey hook looks like this time, and deliver the lens, rotate it a little bit, get the havocs open up. Yeah, look at that rhexis. It's going to overlap 360. I like how the IOL right now is left a little bit decentered. That's in order to facilitate that, going behind the IOL optic to remove viscoelastic. I like that technique. Now you can see that is a beautifully centered, probably 5 to 5.5 millimeter capsulorhexis. I really like this case a lot. This was a fantastic job. Keep up the hard work. Be consistent. If you can achieve this for 9 out of 10 of your cases, wow, you are doing a fantastic job. If you want to learn how to do phaco chop, in fact, you can learn it, I promise you, CataractCoach.com. We have a whole curriculum series. You may be missing out by not using the curriculum series. We have an entire 25-part curriculum series. You should be doing as a resident at least one of these every other week. That'd take you a year, or even better, do one of those curriculum videos a week. And that'll take you half a year, 6 months. You can do it. You've got to put in the effort to become a fantastic surgeon like this young doctor here. I look forward to seeing that last fragment come out of the eye. You saw that too. And I look forward to seeing a future video from this young doctor. Show me case 1,000. I bet you we'll all be incredibly impressed. Wow, keep up the good work. Thanks for watching.